Is it?
ECOG.
I think whatever we call it is electrocochleography. I think is a full term of it. And as I said, there are so many different ways of being able to say that shortened version that I think everyone's correct and no one's wrong. So, we'll continue calling it what we both call it, separate, but similar. We all know what we're talking about, which is great. So, and it's a topic which, as I said, I was very interested in joining and discussing with you because that skill set has really dropped amongst everyone. It's really fallen out of favor with there are a few ENT surgeons who do them. We don't necessarily do anything too invasive as an audiovestibular physician. I'm more a medical doctor, so we try not to stick too many needles into people's ears. We do sometimes, for tympanic injections and things, but not necessarily for injections. But there is the transtympanic one as well, which also is another
Extra
um,
tympanic.
extra tympanic. That's the one. Sorry, the transtympanic is the one which goes through the eardrum, but the extra tympanic one is the one which is just not widely used. So I'd be very interested in hearing about your experiences and to discuss that further. Do you do them a lot?
Yes, sir. With every vestibular patient.
Oh, excellent. And which kit do you use? The EcoG kit.
Eclipse. It's from intracoastal.
Okay. Okay. So yeah, I know Eclipse really well. So we use that a lot for the ABRs and the VEMP testing because
Yeah, it's the
actually I
same
dare
one.
say it's the same piece of kit. You just have to add the other module to it, don't you?
Yes, sir.
And can you do it as part? Do you need a separate module for the EcoG?
Yes.
You do need a separate module, and which always irritates me a little bit because we'd like it all in one go and play with it all, don't we? Until, without the financial outlay.
Yeah.
And how long have you been doing them for now?
Uh, since my graduation, I'm doing this
Fine, pretty
in
much all the
everyday basis.
patients.
Yeah.
Okay, fine. Well, I mean, I don't know. In your presentation, do you have a full introduction to what the EcoG is?
Yes, sir. Uh,
Okay, excellent. Only because obviously there may be people who have joined us today who've never done it, who've never seen it, who may have never heard of it. So it'll be nice to have a detailed introduction about the electrocochleography, about its uses, particularly in the vestibular patient, and what we can infer from the results you've gained so far, and whether there can be other factors that can potentially explain some of the findings and all of those different things. So it'll be really interesting. So I think there are a few more people joining. So shall we give it 2 more minutes?
yeah, sure, sir.
Yeah,
So, sir,
let's just give it two more minutes.
yes, sir. Until
Sorry,
then,
go
sir,
on. Go.
let me explain some. Let me tell you about some ECOG. What is ECOG? How we do
Yeah,
it?
yeah, maybe start with that actually, and you'll probably go through in your presentation, but tell me verbally sort of how you're
Yes, the
doing
brief.
them and your practice. Yeah.
Yes, sir. Uh, Actually, sir, I'm like working with the pioneer doctor, Dr. J.M. Hans.
Yes,
So
you
here,
mentioned I
with
think last time.
every vestibular patient, we perform the ECOG, first ECOG, then we go with the vestibular.
And remind me
VNG.
where you're based again, Vishnu. Whereabouts are you based? Just to remind everyone in the audience, where is your clinic and where are you working?
Yes, sir. Sir, I'm working with the Dr. J.M. Hans and at Vasant Vihar Delhi.
Okay,
And
Delhi.
yes, sir, I have did my graduation just 1.5 years ago from
Okay,
Pandit B. D. Sharma University from Rohtak.
excellent.
So now I'm working with them.
Okay. No, I'll be interested in visiting you guys next time and I'm passing through Delhi. I think it'll be very
Definitely, sir.
interesting to see your setup. So, in your clinic, is it a multi-specialty clinic? Is it a pure ENT type clinic, or is it a vestibular only clinic?
It's a pure ENT clinic, sir. ENT
Hmm.
plus vestibular and plus hearing.
Excellent, excellent, excellent. And so you do the detailed sort of assessment of patients there. So you guys seem to be doing a good job. And as I said, even last time when you sort of presented, it was, in the appropriate structure and everything. So let's start off. I think there are enough people now. It's 10 past. So let's start off by explaining what the electrocochleography is. And if you can give us a detailed explanation, because as I said, lots of people don't necessarily know about these skill sets, do they? So it'd be very interesting to have that detailed explanation followed by the different types and what it means.
Yes, sir. Electrocochleography we perform for a mania disease actually. Uh, in a mania disease, we assess the potentials, microphonics potentials, and submitting potentials, Xing potentials.
Hmm.
First, when we generate the tone, first first we prepare the patient. First cleaning, we put the vertex and ground electrodes on the forehead, and
Good.
we use the gold extra tympanic tip rods.
Hmm.
Then and just
How
do
pla
the
No, sorry, and when you place it, how close to the tympanic membrane do you go?
as much as possible. Like
Yeah,
do it, like push it
because
until
you have
unless
to.
patient is not complaining that I'm
It's very
paining.
much a proximity based response, isn't it? So it's useful to make sure that it's as close to the tympanic membrane as possible. But as we were talking about, there's the trans-tympanic one, which is even better, where you stick it all the way into the cochlea, well, not into the cochlea, but near the cochlea. But go ahead. Sorry for interrupting. Go on.
After the placement, we will start the test and we set the parameters sweeps on 1500. Uh, then our rate is 7.5. The polarity is alternate. We use and high pass filter we use like 1500 to sorry, a low pass filter we use 1500 to 2000.
Okay.
In a high pass filter we use 5K to like 40K, 40
And
hertz, sorry, 5 hertz to
okay.
40 hertz.
And what stimulation are you using? Are you using apologies, I seem to have clicked the wrong button. I'm hoping I haven't lost you. But are you using clicks? Are you using um,
Convert,
tone bursts? Okay,
tone.
fine. Any particular reason why tone bursts?
In tone bus, that the wave is so clear, we can't see the like artifacts, so much artifacts.
Mm-hmm. Because traditionally, I guess a
And
lot of the times where we've done it, we used alternating clicks.
yeah, we use click also, but in patient to patient it differ actually. When we don't
Okay,
get the wave, we use click. When here, then we
fine.
change the tone
Fine.
bus.
Yeah, you use the tone burst at the moment. Okay. And what do you use a particular decibel of tone burst, or is it
Usually we go with 90 dB and
okay?
95.
Fine. And you'll obtain responses in most individuals at that level.
Yes, sir.
Reasonable. What's the lowest you can go? Have you tried that?
Um,
Out of
90
interest.
dB. Hmm.
That's the lowest you would think. Fine, yeah, before you lose that enough of a stimulation, I guess. Fine. Okay, so I'll let you continue. I mean, I don't know if you have your presentation slides. You can bring those up as well, and then we can continue explaining the procedure.
So, sir, our topic is exploring the association of the ECOG abnormalities with positional nystagmus in peripheral vestibular disorders.
Perfect.
Uh, so, the abstract and we explored a little bit about the ECOG and what is the objective and what we did and what is our
Yeah,
results. So,
sounds good.
our abstract background was the relationship between the positional nystagmus and abnormalities in electrocochleography, commonly known as the ECOG, has received considerable less investigation in the field of vestibular sciences. As I've searched, there
Now,
is no positional stigmas related to ECOG. There is no
fine.
article paper, nothing.
Can I interrupt quickly? I agree that I haven't seen an article on that. Is your slide running on your end? Because we can't see anything on our end.
Mm.
Thank you. That's perfect. So maybe we can go to the next slide.
The background is the relationship between the positional stigmas and abnormalities in electrocochleography, commonly known as ECOG, has received considerable less investigation in the field of vestibular sciences. Benign paroxysmal positional vertigo, commonly known as a BPPV, is characterized by the positional stigmas by other conditions like Meniere's disease or vestibular neuritis may alter the clinical picture. So we also see the in the patient. Uh, Sometimes we see the atypical Meniere's disease. Sometimes we see the note. We patient complain that I feel the head positioning nystagmus, the brief sensational vertigo, but when we do the VNG, we don't see the nystagmus there.
So just to sort of clarify that, so these are patients who have positional symptoms, is that right? Or positional nystagmus?
Yes, sir.
Positional nystagmus, correct?
Positional stigmas is there also, and they
Okay,
also complain the heaviness. Sometimes some complain the hearing loss
fine.
is there.
Okay. And you're looking at the electrocochleography findings in this patient group with positional nystagmus. And are you able to break down what the cause of the positional nystagmus is, or is it all BPPV?
It most of them BPPV or
Mostly
some
BP.
some has a mania disease and less have neuritis and unilateral vestibular.
Okay, you go through them, isn't it, in your slides? So let's have a look. Let's have a look.
So our objective is to examine the correlation between the ECOG abnormalities and the presence of characteristics of the consular nystagmus in patients with the peripheral vestibular disorder. Move on to the next slide. The methods. A prospective observational study was performed involving 60 patients experiencing vertigo and balance issues. All patients were underwent audiological profiling, electrocochleography, and video nystagmography. ECOG abnormalities were characterized by the submitting potential and action potential ratio exceeding 0.45. I did the 0.45 or this is our ideal value because we use extra tympanic tip rod. That's why in the intratympanic we consider 0.40. So patient one categorized into diagnostic group BPPV, meaning BPPV, vestibular neuritis, unilateral vestibulopathy, and various other peripheral vestibular disorders. Statically analyzes comprise chi-square test for associate t-test for difference between the submitting and action potential and logistic regression for predictive modeling.
Can I clarify something very quickly, just on
Sure,
that?
sir.
In this group, did they have, in this various different diagnostic groups, did they all have some sort of positional nystagmus?
Uh, Not all, but there
Yeah.
is 48% they had that complaint.
Because of course, with BPPV and MD with BPPV, you will definitely get positional nystagmus, but potentially with neuritis, vestibulopathy, etc., you may not get positional nystagmus unless they have BPPV in addition.
Yes, sir.
Fine, okay. So
And
you've broken it down a bit more. Okay. So it may be plus or minus positional.
yes, sir.
Okay, fine. Thank you.
With neuritis, there is no positional stigmas, but there is a with minute disease, there
Okay,
were so many tendencies to see the positional stigma.
fine. Okay. Well, let's have a look. Let's have a look.
The results were among the 60 patients, 12 patients, 20% had a normal ECOG, 8 BPPV, and 4 others. While 48 patients, 80% had a abnormal ECOG, 29 mini plus BPPV, 3 vestibular neuritis, 2 unilateral vestibulopathy, 14 others. The mean uh, submit SPH AP ratio was significantly greater in the abnormal ECOG was versus normal 0.56 versus 0.28. The p-value was greater than 0.001. The stigmas occur significantly more in the patients with abnormal ECOG. Chi-square is equal to 7.42 and the p-value is 0.006. The logistic regression modeling revealed that for each increase of the 0.1 on the SP application scale, the odds of potential stigmas increased by 1.8, 95% of CI, 1.3 to 2.6. Then the p-value is greater than 0.001. Interestingly, some patients did report positional vertigo subjectively, but did not have corresponding nystagmus in the VMG report.
No, thank you. That's interesting, isn't it? So,
Yes, sir.
and we'll go back to that once you finish.
The conclusion was The abnormal ecology has a strong association with the presence of positional stigmas and the atypical presence, particularly when minor disease plus BPPV overlap in a patient. The results suggest ecology may serve as a adjacent biomarker to distinguish simple BPPV from complex vestibular pathology from other commodities.
So yeah, let's go back to the thank you for that, Vishnu, actually. And I think you do have something there, but for me, I wanted to clarify a few things. And I love the fact that you've done some really good statistics there to analyze the significance of your findings. So if we
Yes,
go
sir.
back to maybe the results the results slide. Thank you, Vishnu. So you had 60 patients, and just to sort of break it down, and also to talk about the indications of why we do the electrocochleography. So electrocochleography, the main finding has always been, or the main use utilization has always been from the perspective of Meniere's disease and to help diagnose Meniere's disease.
Yes,
We
sir.
were saying for those people who've sort of joined us later on, it's semi fallen out of favor because of the fact that many people sometimes don't have the skills to do this or haven't been trained to do this. And there are two different types. There's the one which is the extra tympanic, so you put it by the eardrum, as Vishnu was saying, or the transtympanic one, which involved sticking a needle through the tympanic membrane all the way near the cochlea, and it's quite an invasive procedure. So for that reason, and the transtympanic is actually statistically a lot more accurate because it is a proximity type of measure. So it needs to be close to the actual stimulating end organ, the cochlea, for it to give us nice, strong responses. And as you were mentioning earlier, there's the summating potential, which is the direct current once you stimulate the endocochlea, and it's the endocochlear potential from the actual cochlea itself, and then the action potential, which is the all the sort of
To
nerve
stimulate the nerve.
activities, the synchronous action of all
Yes, sir.
the nerves at the end, and we're comparing the action potential to the summating potential. And because of in Meniere's disease, you have excessive fluid buildup, that action potential to the SPH potential ratio changes. And when it does that, it gives us some more idea that we have endolymphatic hydrops, and which is where where we stand. So going back to your results, just after that brief description, we do. Is there any other indications you can think of, Vishnu, for doing the ECOG? Do you
Yes, sir.
find any? I know you've
Sir,
indicated one of them, but any other things you guys use it for?
yes, sir. I have actually observed while VNV, there is a nystagmus pattern. When there is a patient with mean disease plus BPPV, mostly patient showing the strong horizontal nystagmus. There is a posterior canal patient also, but there is a torsional component less than the horizontal one, so great and intense.
Yeah. Okay. And I think that's going, looking at your results. So you have in the BPPV group, you had 12%, 20% only had normal ECOG. So only 20% of the individuals with, and are we in the 60 patients, to clarify, they all had positional nystagmus or they didn't?
Uh, Sir, they have a mixed symptoms actually, not
Okay.
only the positional.
Okay.
Sometimes with positional they say I have a photosynthetic sensitivity. Sometimes they say I have a heaviness or a fullness. Sometimes they say
Okay.
I have tinnitus, I have hearing loss, but I don't have
Mm,
a heaviness. But I whenever I move my head like side
okay.
to side and up
So,
down, I feel vertiginous.
okay. So they will always have positional symptoms. Is that
Yes,
correct?
most of them.
Okay. So all 60 patients have positional symptoms. S- Some of them have clear positional nystagmus, but of the people where you had positional symptoms, you had this combination of either BPPV or Meniere's disease plus BPPV, vestibular neuritis, unilateral vestibulopathy, and you mentioned 14 others. What are the others? What is it?
Uh,
What
Sir, these are the like some have a labyrinthitis, some have peripheral URI hypofunction.
with positional dizziness and positional symptoms, shall we call it? I'm surprised to see that you didn't have many migraine patients, because I have a huge number of migraine patients who actually present with positional symptoms a lot more, and sometimes with positional nystagmus. So is that, have you excluded that group, or have you sort of looked at that group at all?
Sir, actually, I focus on the peripheral group actually.
Mostly the peripheral. Okay, fine, fine. It'll be interesting to see those results in the central group as well. So back to what your conclusions are. We certainly, in all these people with positional symptoms, sorry, back to that slide. We're just analyzing that a bit longer. Sorry, Vishnu. Um, so with all those individuals with different groups, you found that the ECOG was actually abnormal, whatever pathology they have, provided they have positional symptoms. Is that correct?
Yes, sir.
Okay.
Most of them sir have a mean disease,
Yeah. Which makes sense. What percentage was Meniere's disease again? 29, is it?
29. Yes,
29
sir.
out of 60. So nearly half had Meniere's disease. So they will have an abnormal definite. But then, that's 50%. So we still have another 30% to account for, where you might end up having abnormal ECOGs on people with vestibular neuritis or vestibulopathy, etc. Is that correct? Am I saying this the right way? Correct me if I'm wrong, of course.
Sorry, sir. Can you repeat that?
So we were saying that in the 29 Meniere's disease patients, which is nearly half, which is about 50%, let's say,
Yes, sir.
you would expect the ECOG abnormalities,
Yes,
potentially,
sir.
because they have Meniere's
There
disease.
were abnormalities.
But there's another 30% additional who don't have Meniere's disease, who have other conditions where there are also ECOG abnormalities.
Sir, with the pure BPPV patient, like a 4 BPPV patient, there were no ECOG abnormality was there with
Okay,
pure BPPV patient.
with pure
But with
BPPV.
additional peripheral disorders, there were the positional present, but also the ECOG was positive.
Fine. How many pure BPPVs did you have? Just to again confirm
Eight
that.
patients, 8 patients.
Only eight, only eight. Okay, fine. So most of the other ones had additional, peripheral
Sir, first,
pathology.
first 12 patients with
Mm.
normal ECOG, in that they in 12 patients, we have 8 patients pure BPPV or 4 were totally normal.
It
They
is
have
an
got
interesting, yeah, it is a very interesting finding because, of course, we would only mostly expect abnormal results in the Meniere's disease patients, but here what you're showing is that anyone with a peripheral disorder and ECOG abnormalities are more like, should I say, sorry, let me repeat that. Anyone with a peripheral disorder are more likely to have ECOG abnormalities if
yes, sir.
they have positional symptoms on top of that.
Yes, sir. Actually, that
Yeah,
is the objective, and that is the conclusion that with vestibular patient, with peripheral vestibular patient, we have to go vice versa with epoxy and VNG. VNG, then we should go for epoxy also.
how would you be able to explain that in any particular way? Are you able to explain why these patients with a peripheral disorder, and as I said, not pure BPPV, but a peripheral disorder and positional symptoms, why they have an ECOG abnormality? I'm trying to think about the mechanisms. As I said, I think you have something there which is very interesting. We're thinking about why would it cause positional symptoms, not necessarily nystagmus, in these population group
Uh,
where they had the ECOG abnormalities. How would you explain that?
Sir, actually, my theory is that when Meniere's disease that regulate the endolymph, it
Mm.
also affects the canal fluid.
Yeah.
So that's why it is the Meniere's disease, then BPPV, or maybe the BPPV, the long-lasting BPPV staying for like long time.
Okay.
That treat the Meniere's disease. So
Fine. And that's many years, and fair enough, as I said, the many years part for me, we've shown that. How would you explain the vestibular neuritis and the unilateral vestibulopathy and the 14 others? clearly there's a link between positional symptoms and the and the vestibular disorder. So is there something happening at the endolymph level that when you have neuritis or vestibulopathy that's having an impact?
With neuritis patient, there were no positional stigma, sir. With
No, no, but
neuritis,
they have
no.
positional symptoms you mentioned. Is that correct?
No,
They
no,
will
no,
get
no.
some.
They don't have a positional stigmas with neuritis and unilateral vestibulopathy patient. They do not have positional stigmas, or they do not have complaint of that the positional association.
Yeah,
So with only those patients with mean ADV with BPPV and the single BPPV and these
fine.
four others, these are the patients main.
Fine, okay. So let's go on to your conclusions and try and discuss that a bit further because it is a very interesting finding that you have there. So here, the conclusion is that if you have an abnormal EKG, and that's what we're trying to analyze from those sort of earlier results, so that we can form conclusions, and then we come to the actual there. So the EKG we use for identifying Meniere's disease, and if it's abnormal, you're more likely to have Meniere's. So, but in your case, you find that the abnormal EKG has a strong association with positional nystagmus. So if they have also BPPV, or if they have some sort of positional eye movements, then you're more likely to have an abnormal EKG.
Yes, sir.
Okay, fine. And but if you have pure BPPV, you don't necessarily have abnormal EKG.
Yes.
Fine. So, and what you're trying to say is that if you do the BPPV assessment and you do the EKG, potentially it can either say it's pure BPPV or it's there's something underlying that
Mixed.
BPPV,
Yes, sir.
which I can see where you're coming from, and I think that's a reasonable conclusion to draw. And I do think that maybe what might be worthwhile doing is going back to the results and then breaking it down even further into the different subgroups. So, for example, the Meniere's disease patients, yes, we'll expect abnormalities, but what are the common features in the other ones that we have? You know, the 14 others, the vestibular neuritises, the vestibulopathies. Can you explain what the what the commonality with the other group is, ignoring the Meniere's group, which we will expect the EKG abnormalities? What are the common findings in the other groups?
Sir, if we talk about the vestibular neuritis, there were the nystagmus pattern. If I did the positional test, like
Hmm.
this solfaing head roll test, so
Yeah.
there were if I did the right six solfaing, there was the right nystagmus. Then I did the left, there was still the left nystagmus. So there was a direction
Ah,
changing nystagmus. So that lead me to conclude with the neuritis, and she had a sudden attack and vomit, and
okay.
she was like episode stayed for hours, 6 to 8 hours, and she was like, I was about to die. So
Yeah, yeah. So the
yeah,
typical
mostly
acute
with female.
vestibular neuritis.
There were three neuritis patients, three were females.
Hmm. So I think you have to, and so with the obviously with the acute neuritis, you'll have that spontaneous nystagmus anyway, which will exacerbate when you move your eyes, as per Alexander's law, and you will end up with some positional nystagmus in them as well. With an additional sort of positional component in some of the vestibular neuritis patients because you've got a spontaneous nystagmus anyway, which changes or which exacerbates as you do the positional testing. So
These are the
that's number one.
pre-existing studies that showed in the test,
Hmm.
positional test.
How do they tolerate the test, the acute patients?
Sir, she came to me after like 15 days after attending
Okay, okay.
first attending.
Yeah,
So
fine, fine.
it was like resolving phase. It was like very less than I did. She was feeling vertiginous but less manageable.
Okay. So I guess from my perspective, it's certainly worthwhile exploring this a bit further, isn't it? So you want to really clarify the idea that you have and then to break down the different groups. And you probably want a few more patients in the normal group because to compare, to do a direct comparison. And you'd also want a few others. So apart from Meniere's disease, people with ECOG abnormalities. So then you can really truly compare the normal ones, the BPPV, versus the Meniere's group, which will be people with episodic vertigo and vomiting, nausea, unilateral hearing loss, etc. And then we'll come back to that in 1 second. But then you'll also want a lot more individuals or patients in the other group, the ones without Meniere's disease, with the ECOG abnormalities. Then you can really truly have three individual group and do a cohort study across the different groups, and to identify the patterns. But it's an interesting finding, and I think it's a very useful thing. And I'm thinking, maybe we should have that. We should start exploring this again, because as I was mentioning, it's a skill that's fallen out of favor, and particularly the transtympanic one, the extra tympanic one, which is less invasive, may have an additional utility in the wider vestibular world. And sometimes these things come and go out of fashion. We forget about them. There's always a timely reminder that, well, if you have the kit, it's certainly worthwhile collecting the data, and ultimately you're at the cutting edge of seeing these patients. You just have to have a clear idea in three separate cohorts, so that you know exactly what the three cohorts or four cohorts are all doing, and what the commonality is and what the differences are between them. So then you can compare the test results between them as well. So no, thank you. That's very useful. The final question is, how do you at the moment diagnose Meniere's disease? Is that a clinical diagnosis, audiometric diagnosis? Is it a vestibular test diagnosis?
Sir, whenever I go with lineages, I go with tetrad actually. Hearing loss, tinnitus, fullness, or
Hmm.
vertigo, long-lasting vertigo. Are,
Do you
are
guys, fine, I think, which is a typical symptoms, isn't it? And that's the
yes,
classic
sir.
symptoms. Do you use the Barani Society guidelines at the moment?
I with vestibular migraine, not with lineage.
I I think it's worthwhile, because of course they're now the established research guidance when it comes to diagnosing various things, and particularly if you're doing research work, that's the one thing that people will ask, is it, are you using the Barani criteria? Can you prove it, that you've been using the Barani criteria? So I do encourage people to stick to that now accepted terminology, I guess, which has been put out by the self-proclaimed leaders of the vestibular world at the moment. And fair enough, if they've established research uh, diagnostic criteria, I think it sounds reasonable, so that we all use it, so that we all have the same exact definition across the board. Different countries, different continents, it doesn't matter. Everyone will use the same diagnostic criteria. And number two, there are now, and part of the reason why things like ECOG has fallen out of favor is because of the fact that now, when we suspect Meniere's, we're putting people through specialist delayed contrast scans. I don't know if your doctors do that at the moment.
Yes, sir. We do CT at our center.
Okay, but
CBCT.
they're not CV. Oh, I see. That's one option, and I think that's in the. But more recently, we've been doing sort of the high Tesla, so 3 Tesla MRI scan of the inner ears with a 4-hour delayed contrast. And there's been a few papers that's been published with various groups. One of my sort of colleagues, which actually you can then grade the amount of high drops within the endolymph itself of the inner ear. So that's the latest sort of techniques we're utilizing. It it does have its own problems, don't get me wrong. So, as I said, the ECOG might be
And what is
another
the radiation
addition.
for that?
Sorry, what's that?
Radiation? Radiation level
That's
for the
radiation, you said? It's Oh,
radiation.
sorry, this is Siri is talking to me. I thought it's talking to you. But radiation, so it's an MRI scan, so there's no radiation whatsoever. the gadolinium contrast is the only one, which is the slight concern, but that's contrast reaction rather than anything else. But otherwise, it's very well tolerated. And being an MRI scan, there's zero radiation. So hence why, while so cone beam CT is good, I think that just offers a higher resolution imaging of the endolymph. So it's worthwhile looking at those papers. There's a few papers that's been described. It's what we call 3T or 3 and T for Tesla, MRI imaging with delayed contrast. So they give you double dose of contrast, wait for 4 hours, wait for it to permeate into the endolymph. And it's what we sort of currently utilize for most of our patients who we suspect has Meniere's disease. But equally, as I said, it is not one which is easy to do. You need lots of expertise. You need not just the doctors, the audiologists, etc. You need the specialist radiologists as well. So, which is where I think things like EQT still have a strong role because it gives you an easier, quicker answer. But we just need to clarify. Okay, shall we open it up? As we've come to a nice discussion, and it was very interesting. So thank you, Vishnu. Really do think that's something worthwhile sort of studying further, and I do think you're onto something. So it was a good analysis and presentation. So shall we open the floor up? Any questions from anyone? Feel free to unmute and talk out, or type it into the chat box. Hopefully, if someone has access to the chat box. Is everyone sort of clear about what the electrocochleography is? And if you had any questions, Vishnu's now got has loads of experience performing them. He might be able to give you a few tips and tricks. If anyone wants to ask anything about Meniere's disease, we can talk about that as well. And BVPV, that's one of the other things. Electrocochleography and electrovestibulography are the same. No, would you like to take that, Vishnu, or shall I answer it? But the answer is a quick answer is no. Is electrocochleography and electrovestibulography the same thing? I'll be honest. Do you use the term electrovestibulography?
No, sir. We don't use
No.
that term. I have heard
okay.
first time.
So if you're talking about electronystagmography, that's the electrode-based nystagmography instead of video nystagmography. But electrocochleography is where they put a loud sound in your ear. They do it either through the tympanic membrane at the cochlear level, or they do it extra tympanic membrane. And it's a bit like an ABR. I think that's probably the closest analogy I can offer. It's a bit more like an ABR because you're stimulating the inner ear and you're acoustically stimulating it and getting a response. Does that sound reasonable, Vishnu?
Yes, sir. Only for higher intensity because the potentials only generate on higher intensity. It's not lower intensity.
Correct. Any other, and I think the only other test which we can probably do, and that might be of interest as well, Vishnu, VEMP testing. The VEMP testing is might be the other thing worthwhile comparing in this population. As you know, the 1000 to 500 hertz ratios may again indicate Meniere's. Having said that, we still need to analyze that data. We haven't got that much excitement out of it. It'll be interesting to see if you guys have any data from that. Is EKG invasive or non-invasive procedure? So we were, yeah. And I'll let you explain, Vishnu, so that it's very clear.
EKG is an invasive and non-invasive both. We can do in a both way. Invasive, as sir said, intratympanic. We have to pierce the tympanic membrane and that will place the electrode on a promontory. Then we get the direct response. And then it's a non-invasive, such as we just like I do, gold foil tips we use. We place here, then we attach the impedance wire. We got the response. Just like ABR. It's a non-invasive, just like ABR.
Perfect. Next question is, how does waveform differ for Meniere's disease and auditory neuropathy? And I think They are two very distinct things. So neuropathy, you may not get any response at all because the nerve is not working. Whilst you'll get a cochlear microphonic when you do the ABR. So that's the cochlea responding. And when you do the ABR, you'll be putting in sort of rarefaction and condensation type clicks, so, and reversing polarity to try and determine the true cochlear microphonic, which comes from the cochlea, but the nerve won't be working. So there won't be the rest of the ABR present in auditory neuropathy spectrum disorder. But in Meniere's disease, it's a completely different type of test. It's more, as Vishnu was saying, either you put alternating clicks or you can put tone burst, and you will be measuring a different measure of the inner ear, which is called as the mating potential and the action potential. So they are two different things. There are two different tests also, and they provide completely different answers and traces. Does that sound reasonable, Vishnu? Or do you know if you wanted to add anything more?
No, sir, you are absolutely right.
Hopefully that helps answer the question, Tanya. But feel free again to. For all vestibular disorders, is EKG compulsory? I think this is what we're deciding at this point. I think this is what we're exploring, and it's a very useful presentation by Vishnu because it got me thinking again. It's fallen out of favor in a lot of places. We don't do it routinely because I guess it gets lots of tests come into fashion and then they go out of fashion. And ECOG is one of them, which, like Vishnu was saying before, a long time ago, they used to put a needle into your eardrum to measure the potential. But now there's the one which you just put it into the ear canal. You don't have to pierce the eardrum. And it's a lot easier to do and it's a lot safer to do. But the fact is, it's just been forgotten about and it's not compulsory. We, I think, need to have more data to find its true usefulness. At this point, it's unclear. If you have it available, I think it's worthwhile doing it and trying to explore like Vishnu is doing and trying to understand the utility of it in the wider context. If you don't have it, well, you don't have it. It's not essential. I think a good history, a good examination, VNG, VHIT, all of those are standard and established practices which you can continue doing. But maybe things will change. Vishnu gets more data, publishes a good paper, do a cohort study. Maybe we can all do that. Yeah.
And then I would like to add a bit more that if you have available this EPOG, you can try it for comprehensive assessment, but that
Agree.
is not necessary that you have to do it with central patient at least. If you have suspicion of peripheral, you can go for it if available.
So the next question by Sankar is why in the case of Meniere's disease do patients vomit and the symptoms do not relieve until vomiting occurs? And I think there are more theories about this more than anything else, because why does any vestibular disorder cause
We have nausea and
nausea?
vomiting. Yes, sir. This
Yeah.
is the question actually.
There are reasons, and partly because, and I think the theories are predominantly about the evolutionary requirement. Because back in the days, when you used to be poisoned as a animal or as a human being, and it's predominantly in a case of ingesting something, you will get the symptoms of dizziness. So it's almost a body's natural reflex to try and expel what you've ingested, and hence vomiting. So that's one of the theories.
In fact,
Go
I would
ahead.
like to add more that
Yeah.
Dr. Hans, I have heard him to counseling the patients that why nausea and vomiting, and I also talked to him about it. So
Yeah.
he said that the vagus nerve is uh, some supply in the ear, then heart.
Yes,
So that
correct.
is the reason that it is stimulated that nerve, so we feel nauseatic and vomiting.
Yeah. But the
So
question then remains, why does the vagus nerve? Everything's by design.
this,
I'm a great believer in that, and believe in God or not, everything's by design, and God may take many forms. And so there's a design reason for that. And hence why I was exploring the evolutionary side of things, is it because, and that's one of the sort of current theories. So I agree the actual mechanism is the vagus nerve, but why? And why is it could be by accident, but I suspect it's more designed on purpose to expel any contents in your tummy, which will make you poisoned and which will cause you dizziness.
yes, this
Hope
why.
that makes sense. Hope that makes sense. Any other questions? Last few minutes. If not, we can wrap up. Oh, good question. How long will it? This is a good question for you, Vishnu. How long to do the EKG?
I I take 15 to 20 minutes. In within half an hour, you will do the test.
It's a nice quick one, isn't it? And it's tolerated by patients well, even if you put it deep inside the ear canal.
Yeah, they get
And
to
then
sleep.
Sankar, yes. And then Sankar was also talking about the vagus nerve stimulation, stomach reflex, and peristaltic movement, which I think absolutely, I think there's the mechanism, the actual vomiting is secondary to the vagus nerve, makes a lot of sense. But why? That's the $1 million question. There must be a reason. EKG in vestibular migraine is a question by Shruti, and it's a separate study. I think we were talking about that earlier when we looked at the results, isn't it, Vishnu? Because EKG is would be interesting to see in the large cohort. Here we're talking today only about the peripheral conditions.
Yes,
Um, it'll be very much. I'm sure you have a separate cohort where you have it in vestibular migraine and central vestibular disorders patients. So that may be for another day. But at the
definitely.
moment,
I'm
yeah,
working on it.
good, 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 good. And it'll be anything else? No, excellent. Well, listen, I think we've come up to near our time. I'd like to thank Vishnu, who's been a great presenter today, and I think brought
I think
forward
you have
and
a few
brought to
more
light
slides.
again. Sorry, say that again.
I have few more slides, I guess. Oh, another five, six slides. Are there.
There's more slides.
These are the detailed version of the this article.
Oh, I see. Okay, that's fine. It's the same thing, right? We've discussed everything.
Same thing.
Fine. Okay, lovely. Thank you, Vishnu. We can unshare now if required. And I wanted to thank, of course, Vishnu from Delhi for kindly presenting his interesting study and bringing to light the ECOG, which is being forgotten about. So, may even get me starting to do them again. So, because it is an easy enough test to do. I think at the moment we still need to show its exact value, but just because it's been forgotten about doesn't mean it doesn't have any utility. So, I think this is where we're exploring a lot more. And vestibular science is very much an evolving area. It's quite exciting, isn't it? There's lots of things that we need to explore and and analyze and learn from. So, and nothing should be forgotten about. So, thank you again. Well done. And hopefully next time you can show us some more data on the more vestibular migraine type of conditions with this test.
Yes, sir.
Okay.
Yes, sir. I'm working on it.
And
Like something special. So
sure.
soon enough.
And
Thank
of
you,
course,
everyone.
I don't know how many from today have joined from the course, but as you know, we're sort of running a vestibular course for audiologists and physiotherapists and everyone. And I might see you guys again well, I will see you guys again on Saturday if any of you are from the course. And that's a 6-week program, so I'll be seeing all of you on a regular basis. But other than that, we'll bring this to a close, and thank Vishnu again, and thank Cyclops and our Cyclops Vishnu for organizing it very nicely.
Yes. Thank you, Cyclops.
Take care.
Thank you. Thank you.
Goodbye.
Thank you.